Please.
Good evening all, honored guests and friends. Thank you for taking time out of your busy schedules to join us here to discuss the care of the elderly in a modern day society. We have a lineup of great speakers here tonight, and to kickstart the evening, I'd like to invite Mr. Rekha Khandelwal, retired government servant and founder of the Vardhan Hospital in Vardhan Senior Citizen Center.
Verify that I am not the founder of Vardhan Hospital or Vardhan Center. I am just a proposer of this cause. But my heartiest welcome to you all to this collaborative program on senior citizens. And this program is especially meant for super seniors who are gone much beyond the age of the ordinary seniors. But for that, I must say that the cause for our motivation for this cause was provided by a very eminent Indian, Mr. Cherian's organization helping Mr. Moni Sabharwal has been the real motivator of this cause. And really I must say that I miss Mr. Cherian very badly. Vardhan Hospital from its very beginning was taken up by Mr. Sabharwal as a resource for senior citizens, and that motivated Dr. Rekha and Dr. Rajiv to do whatever little bit they could do for this cause. Dr. Rekha will be dwelling on the purpose of this program in extenso, but I have just to say that say something out of my own personal experience. I am now exactly in my mid-80s. I am pretty active and have led a very active life, some small thing. And it is then that I feel the need of a setup, of a devoted setup for super senior citizens, as I have already emphasized. We will start this program now, but while we people from the desk will be addressing you and talking to you about this matter, I particularly want substantial contribution to come from the floor. So after the program, I would request you to please come up with your questions, queries and suggestions. Request now and Mr. Cherian to kindly provide the introduction of the subject. I've already told you about Mr. Cherian. He is connected with the helpage, is now the current boss of the helpage.
Mr. Cherian will be discussing the care of the elderly in our society and what his organization is going to do with it. He is the CEO of Helpage India.
Dear Mr. Khandelwal, Dr. Rekha Khandelwal, Ms. Usha Banerjee, esteemed guests who have come here, and thank you Rekha and Vardhan for inviting me to speak here. I've been asked to introduce the subject. So I'll begin with a small presentation to just introduce the problem. And today we are actually 100 million elderly in India. That is how elderly population has grown in this country, and people above 60 years are above. But if you look at the map of India, I come from the southern tip of Kerala, which is already aged faster than North India. All the southern states, which are marked red, have aged faster than northern India. The states which have not aged so much are the poorer states. The Uttar Pradesh, Bihar, Madhya Pradesh, Chhattisgarh, Rajasthan, to some extent Gujarat also has not aged as fast as.
As very relevantly, they are known as Bimaru states.
I didn't want to use the term Bimaru because there's nothing Bimaru. So that's 12 million are blind in this country, and this is because they cannot afford 1,000 rupees per cataract operation. And there are 30 million people in this country who are elderly, who are lonely. And this is more than the entire population of Australia. Various reasons. Children are not living with them, children have migrated, and sometimes it is the loss of the spouse. So various reasons are there. And but overall, 90% of the elderly have to keep working in this country. If they have to survive, they have to keep working, because there is no social security in this country. And HelpAge has been advocating for universal pension. Hopefully it may not come in my lifetime, but I see younger people in the audience. Maybe in your lifetime you will have a universal pension in this country. So that is what is happening. And today's discussion, if you break down the population, there are about 65 million elderly who are working. There are destitute elders, which is about 11 million. That is the population that HelpAge India serves, because we work with the poor and the destitute. And then there is assisted elders, which Rekha's organization is working. We have Gracious Living Foundation, which are working with elders. These are elders all who require some form of assistance. And like it may be, so in some simple cases it may be just a walking stick, but in more complicated cases it may require more medication and care. So this is some of the areas that we have. And HelpAge is also looking at the terminally ill. We have a big problem in India that there are terminally ill patients, and it is not a small population, it's quite a large population. And in fact, we are quite obsessed with what we call as end-of-life issues, not because we love death or we like death, because we think that dignity has to be given to older people at whatever age. Even when you are close to death, you should die in dignity and not die in. So that is the objective. So today's discussion is also, how do you look at these people? Of course, Mr. Khandelwal said at 85 also he has some problem every day. Of course, I also have problem at a much younger age every day. So it's not, but what happens is when you have a terminal illness or you have some major thing, you need support. And that support will not come from the children. That support will not come from, the support will have to come from elsewhere. That is the reality of India. I'm not talking in a negative way, because that is the reality of India, because children have to go maybe abroad, maybe other places to lead their own lives. And I came from Kerala all the way here. So like that, some of them may go to another country to survive and prosper. So this is end of life, and 9 million people are with terminal illness. This is the data of the World Health Organization, and every district has close to 5,000 people. And so what is happening is, in our HelpAge's mission, we like that all elderly have to be active. And active aging is a combination which I hope all institutions, whether it is help-age or we have to see that elderly remain active till the end of their lives. And active aging is a whole area which requires good health. It also requires good participation, which means you should be involved with other people, because all of us, we are social animals. We require company. So if there is no participation, if you are involved with your RWA, if you are involved with your various activities in your colony, you will be more active. And last but not least is the security, which is a big problem in this city of Delhi. Everybody is unsafe, including young women. Even older people are as unsafe as young women. So unless we have these three facets, we will not have a foundation. And I'll stop with this slide because he has given me only 5 minutes. He may strike his pencil. But this is a figure that all of you have to understand. The care pyramid is something which you have to be very conscious of. At the bottom of the care pyramid is the community. You will have a good care if you are networked within the community. And your neighbor, Jesus Christ said, love thy neighbor as thyself. But unfortunately, in today's India, there is no love for your neighbor. In fact, the neighbor is the most hated person which you can think of. But actually, he is most important when it comes to caring. In times of crisis, he will be the only person who can get you to a hospital. So community is very important. And then we need volunteers, because children have to go and talk to seniors. Young people have to interact with seniors. And unless we have that interaction, life in old age will be terrible. Then we need some form of home care. It could be through caregivers, it could be through physiotherapists, it could be through any sort of, you need some level of home care. And today's discussion will be on the top of the pyramid, which is the medical support and the referral services. And that is what, of course, Vardhan is trying to do. That is what many other institutions are trying to do. We are also trying to do. But at the same time, there is an issue which we need to consider. In India, most people do not have an adequate pension or a social security to back this medical care. And if any of you have more than one health episode, which means if you have a heart problem and combined with it, if you have a knee problem, then what will happen is you will slide into poverty, irrespective of whatever pension you have gathered and whatever you have. So this is the reality of India. So we need to really look at the cost of healthcare, which of course is going up in it's an upward spiral, and we need to control those costs also. So this is something which we need to do. And then last but not least, actually I'll skip these slides because of the patient. And this is some of our work that we do with terminally ill. But what I would like to say in closing is, as elderly, most elderly suffer from chronic diseases. And in chronic diseases, the best support can come from the community and from the family. And so this is what you will have to look at, because if you can look at community, society and then family, then you will be better off. Then, of course, we work with the terminally ill, and most terminally ill tell me at the end of their lives, I don't want to die here. I want to die close to my children. I want to die close to my family members. And most people, even in our homes, keep telling us, call my children, call my loved ones. But unfortunately, they never come. So that is the reality. So I hope you will have a good discussion. Thank you. Thank you for your attention.
Thank you, Mr. Chairman, for the great introduction. Now I'd like to invite Dr. Rekha Khandelwal, practicing gynecologist and founder at Vardhan Hospital and co-founder of Vardhan Senior Citizen Center, to speak about the challenges in running an institutionalized medical care facility.
Dear guests and friends, good evening to you all. Thank you for your presence today at this discussion about the changing dynamics in our country which is highlighting a great need for care of medical independent seniors. Modern Indian families are changing and evolving. Medical advancements have increased the lifespan of all, and increased pressures of urban living and chaos has created a gaping hole, and the needs of the elderly are often overlooked. And a need has therefore arisen to cater to the growing elderly population and provide quality and affordable medical care to the elderly. The idea for Vardhan Senior Citizens Home germinated when I saw patients, relatives, extended family members struggling to be able to provide the care and attention that the elderly needed. Apart from their daily medicines, their personal hygiene, they also had to take care of their medical needs. And it was not always possible to do so. So, senior citizens homes like ours have come up, which take care of the elderly and give them the comfort also that medical care is available round the clock. The immediate family members would like to take care of their loved ones, but however hard they may try, sometimes it is not always possible to do so for various reasons. In my last 7 years of running Vardhan Home, I have come across many scenarios which I'll discuss in the next few minutes. The first issue is about the nuclear families. Nuclear families have become very common nowadays. India has always been a place of joint family system, but gradually it is breaking up. Even people who are living in joint families, most of the youngsters are working. And the young children have left for greener pastures and have got used to an independent lifestyle. Now, when a senior becomes medically dependent, in both scenarios, in a joint family and in a nuclear family, there is a lot of adjustments which need to be done. And there is a lot of emotional upheaval among the members. Initially, all of them want to take care, but gradually, the reality starts sinking in and stressful situations arise. The elders start feeling neglected. They feel insecure when the children are out working. They also feel that the children are not spending time with them. For the youngsters, they have to make special arrangements for physical, if they have to make physical efforts, they have to make arrangements in the space, and they have to give time. They have to look after their food requirements, and when at work, their mind is always wondering as to, are my people, my elders secure at home? Are the caregivers giving them enough help? Are they good? Are they doing good supervision? And what if there is a medical emergency? One more problem is about the transportation of the seniors for the doctor's visits. The children have to take out time of their busy work schedules to do that, which is very difficult at times and leads to a lot of interpersonal problems among the children. There might also be a scenario in which a senior might be residing in a different city or a country. And it is a situation where there is personal grief and stress both for the senior and the children, because they are always worried as to what is happening, who's taking care of, and is the care good. When they are put up in senior citizen homes like Vardhan, the personal attention is being taken care of, medical needs are being taken care of, and the immediate family members are also kept in the loop about their personal well-being. It's a big comfort for them. And I have also seen there's a tremendous improvement in the relationship of the seniors and their children when they are put up in homes like ours, because adjustments in the families are no longer needed and medical help is readily available. One more request which I frequently get is about short-term care. At times, times family requires senior citizens to be institutionalized for short term in the following scenarios. As a step down management after a medical or surgical condition, for short term rehabilitation following knee surgery, hip replacement or osteoporosis. These requests are very frequent and most of them are also coming from my neighborhood because the children have the satisfaction of leaving them under good care, and in the evening or at weekends when they come, they can interact and relax with their seniors. One more request comes from the working couples when they have to go out for work for a few days to a few months. Because nowadays couples have to travel out for work, and in some cases both husband and wife have to travel. So they are very insecure when they leave their elderlies at home. The other issue is of the tight living spaces in India. Today's modern day nuclear family hardly has space for themselves. And many of them are living in small, cramped, matchbox-like apartments where there are no facilities like lifts or even senior citizen-friendly ramps. Their houses are situated in narrow, congested lanes where sometimes even an ambulance cannot enter. Now, if the onus of looking after their medically challenged seniors comes on them, space is a big constraint. I want to tell you about a lady who is with us. She's suffering from a chronic respiratory disease. She needs oxygen all the time. She's living with her son's family on the 3rd floor of a cramped place. Now the son has great problems transporting her from home to the doctor for her frequent visits. And because of the space constraint, all the gadgets are also not fitting in the house. That is why she's with us, and both the son and the family and the lady are comfortable because she has sufficient space for herself and the quality of care is also good in our place. Now, a word about the professional caregivers. Professional caregivers are very scarce. They are not easily available. So in that process, the domestic help and the nearby people are to do the caregiving. That is generally not up to the mark because every senior who is medically dependent needs customized care. But because of paucity, because of the cost issues, these helps are hired. I got a very nice, beautiful looking air hostess. She had dementia, and in her case her family had left no stone unturned to get the best of caregivers. They had hired a technician for her to dress her bedsore also. But because of lack of personal supervision, which the caregivers require, the professional or the hired caregivers required, and the lack of medical supervision, her sore became non-healed. When she came to us, it had to be cut open. In that process, her entire back was exposed, her backbone was exposed, and she had to be given a lot of blood and supportive treatment. So, this is one major issue which is facing our country, and we need to have more and more of such homes which give training to caregivers also. The other thing is the unavailability of doctors. For various reasons, doctors do not want to do home visits. And even if they go for home visits, they do not want to travel at night because of security reasons, as all of you are aware. Now, suppose a doctor goes and there's a medical emergency. Number one, he might not be able to reach there on time. Secondly, even if he reaches there, he cannot tackle a medical emergency without adequate equipment and adequate help. So, when these people, when the elderly are put up in homes where medical care is available, this problem is taken care of. Lastly, I would like to talk about single seniors. In my home, most of the people who are living are single because an active single senior can look after himself or herself. But the moment he becomes medically dependent, it is a big problem. It is because they cannot look after the house and they cannot look after their medical needs together. My experience with a single gentleman who was 85 years old, belonging to a upper middle class family, was very heart-wrenching. He lost his wife to cancer and he could not look after the house. He did not know how to cook food. In that process, he became not only malnourished, bedridden, but also medically neglected, because in his case, his wife was taking care of his medicines and all, and now he didn't know when to take those medicines, what to take. It took us almost 3 months to bring him back to normal, but still he is in severe depression. So the concept of retirement homes is coming up. More and more retirement homes for all categories have come up. People are very happy there. The seniors are happy because they find their own company. They don't have to worry about getting early in the morning lest they disturb their children. They have their own social network. But when they become medically dependent, there is a dearth of homes which take up medically dependent seniors. Though hospitals are there, but they lack personal and homely touch. And they are expensive also for step-down management. Now, even if a good hospital agrees to give step-down management, it would cost somewhere between 6 to 10 lakh rupees per month. In such cases, an institution like ours, which is easily accessible by the near and dear ones, being situated in the heart of the city, is a great help to them, because we believe in providing a personalized care at a fraction of cost from the hospitals. We do not really believe in making a profit at the cost of the elderly. That's all I have to say today. Thank you for gracing us today. We'll be taking up questions later on. Our brochure contains the detailed information of our home. Thank you all once again. Thank you.
Now we have Dr. Vipul Rastogi, consulting psychiatrist at Medanta Hospital, and he will be discussing dementia and related neurological disorders in the elderly.
About 5% of people over the age of 65 will have dementia, and this rate doubles up every 5 years. So we would expect a 70-year-old person or people of 70 years of age having about 10% people will have some form of dementia. We are living longer, so the dementia is getting more and more recognized. We would see a lot of people come to me with the family members, and what you would notice is, I generally explain that depression is a person's own illness because it kills you from within, but dementia is the family's difficulty, because the person usually in the severe form is quite oblivious to the change and they do not understand what is happening to them. So dementia, in simple words, is an impairment of multiple abilities, so not just memory but also associated with it their difficulties in maintaining their own activities of daily living, social relationships, occupation, and this diagnosis is based on history itself. There was a big survey done in neurology that most of the diagnosis can be made, 80% diagnosis can just be made by an informant. About 10% you can make further by doing your physical examination, 5% extra by doing some kind of test, but 80% you can just by having a good history. So a very good history is very much necessary. Now, the important thing is that the clinicians must compare a person's present abilities with what they used to do before, because a decrease in ability of a person who is uneducated may not be that much noticeable, but somebody who, say, for example, used to be an engineer or a doctor, being unable to do what they used to do, or will be much more noticeable. So it is very important to compare what they were able to do before and what they can do now. Another associated condition is delirium. Now, delirium is a state where people are usually, it's an impairment of their attention, so they do not know what day, date, time or person. Now this is very common, and you will see more and more in general hospitals where people have had major surgeries or they have been admitted for a long time. Worth noticing here is that some people might be oriented to time, place, and person, but they cannot sustain attention. So if you ask them to say, digits from 1 to 10, that is easy for them. But if you ask them to do from 100 to 1, they're unable to do. Or if you say, can you tell me the months of the year from December to January, it's difficult for them because they cannot sustain attention. Now the important point here is that if you want a diagnosis of dementia, cannot be made in somebody who's in delirium. So it is important to be able to differentiate that, although the presentation might look a bit similar. Now when we are evaluating dementia, the most important aspect is to look at reasons which can be modified or which are reversible causes of dementia. So as a doctor's expertise, that is the first thing that you need to do. So these are things like people having brain tumors, or people using a lot of alcohol, or having blood clots, or simple things like hypothyroidism, so the thyroid gland is not functioning properly, or diabetes. Medication, I mean, a lot of elderly people are on a lot of tablets, and they can also have an impact on the cognition, memory, and drowsiness. So that is very important to keep in mind. As I was saying before, the history is the most important aspect, and looking at how the person's functioning has deteriorated. There are certain tests which are essential, which are here. Some of them are simple blood tests, and some are tests of imaging, which are like MRI and CT scan. I can go into more details if people are interested, but as again, a good neurological examination and a good psychiatric testing is important, which are just communications of half an hour. There are certain tests which can be done, paper tests, which take about 5 minutes. So if people are able to give 5 minutes, then you can actually come to some kind of diagnosis very quickly. Some of the tests are desirable and are not recommended for everybody, and depending on case by case circumstances, then these might be needed. I won't go into details of these. So what are the criteria when you're diagnosing somebody with dementia? So the most important one is having memory impairment, whether it is short-term or long-term. Mainly it is a short-term memory. So example of this will be people will be able to remember when they got married, what was their date of birth or children's date of birth. But if you ask them what did you have for breakfast this morning, then they may struggle, or what did you have for dinner last night. So usually there is a bit of embarrassment and they might just say, oh, I had dal, but if you push them what kind of dal, they can't. So that is very important. Now only memory impairment does not make a diagnosis of dementia. Also you have to have things like speech difficulties, or people having difficulties with motor coordination, so being able to comb their hair or put the buttons of their shirts. Executive dysfunction, this basically means being able to know what is right and what is wrong. This is what makes executive functioning makes us different from animals. So you may have a wish to, if you see an empty road, to drive at 100 miles per hour, 100 kilometers per hour, but you don't do it. So that is your executive functioning, because you know that this is not right. So there's a specific kind of dementia which affects the executive functioning, and you have a lot of behavioral difficulties, and that is the most difficult part for the families or the caregivers to negotiate. Now, along with these impairments of memory and other things, there also has to be a decline in the social functioning, social occupational functioning, and this has to be compared from the previous levels. Some usual kinds of dementia. So the most common one is Alzheimer's type dementia. Now this has a progressive cognitive decline, so the person declines gently and smoothly. Usually they're unaware, they may have no motivation, and towards the latter part of it, after 5-6 years, they may have psychosis, which means having strange experiences like hearing things or seeing things when nobody is around, or they can have agitation, which might be some kind of aggression towards personal care. Speech is usually fluent, so they're able to speak like I'm speaking, but there's not much content in it, so it will be very empty. So if you show them, say, a picture of an elephant, so they might just say it's an animal, but they will not be able to say what actually it does or what's the function of things. It is also followed with, depression, also some delusion. So this is the psychosis or the confusion. A lot of people here would not be able, might have things like that they do not recognize their wives or their sons. They might say they are an imposter, which is very difficult for caregivers. And there's something called sundowning phenomena, so people are much more bright and alert in the day, but as the sun goes down, so they become more and more confused. Another one is vascular type. Some people might say that this is the most common in India because we have this metabolic syndrome, which includes diabetes, hypertension, which means high blood pressure, obesity, and cardiac problems. So this occurs because of people having strokes. Now these strokes may not show up, or they may not be some which may cause unconsciousness, but these might be mini strokes, so people may not come to know of it. You only come to know of it when you do scans, but these scans are also do not confirm that the functioning deteriorates, and it is classically a stepwise. So there will be a deterioration in functioning, then there will be a bit of stability, then further, just like stairs. So usually most of the dementias are mixed types, so a bit of vascular, a bit of Alzheimer's, and we'll talk about further. The next one is the dementia. This is associated with Parkinson's disease. So again, like Alzheimer's, progressive cognitive decline. So it's a smooth decline, but a lot of people will have symptoms similar to Parkinson's disease, which are tremors, slowness, and rigidity, which means they find it difficult to move their hands and feet. The specific part here is people are more alert at some times, and at others they are not so well alert. And they also have visual hallucinations, which are typically of, they might say we see small animals here and there running around in the room, and they may also see people standing. It does not disrupt the memory as much as Alzheimer's. It is not that common. The most difficult one to treat as a doctor is the frontotemporal dementia. Now this is the one which comes early in life, and it's most likely this runs in family, so you might have a history. There's a brother who's similar, or the mother had a lot of difficulties. Usually starts in late 50s, so much before the age where Alzheimer's usually is. Memory is good, but a lot of behavioral difficulties like urinating somewhere or being aggressive, abusive, hitting out at people. There are two types. One of them is the aggressive type. The second one is the apathy type, which is people do not have motivation. They're happy to sit as they are. So the food might be rotting next to them, but it does not bother them. Now, a little small word about head injuries or traumatic brain injuries, which may be, but I'm also trying to include people who have had encephalitis, which means brain infections, and the brain is not working that much. If it is just one head injury or one time people have had an infection, then we do not, the dementia or the loss of functioning or the memory is stable. It stays at the same level, it does not go down. And different parts of the brain have specific functions, so the deterioration will depend on what part of the brain does get affected. So if it affects the frontal lobe, then you will have again the frontotemporal kind of dementia picture. Treatment, we largely say if people have dementia, then try and use non-medical or non-medicinal ways. So one of them, I'll just give some examples. So one of them is diversion or redirection. So if the elderly person is saying, I want to see my mother, and you know that the mother died 30, 40, 20 years ago, then you just say, okay, we'll do it later, let's go and have lunch, or let's go and have breakfast. So it's about diverting. Reassurance, if the person is scared that some people are imposters or some people are coming to kill them, you just say, okay, I'm here with you, and we tackle it together. Avoid confrontation, so there's hardly any point to say that, well, your mother has died, she's not there, because this will just agitate and disturb the person itself, and keep them busy. I think in India we have this notion, if you're getting older, then don't do any work, but then doing some work is very important to maintain people's self-esteem, confidence. It doesn't have to be hi-fi work, but even things like chopping vegetables or folding the laundry or just doing some knitting or stitching is equally good because it maintains your brain functioning, and also it keeps your self-esteem. In terms of medication, I won't spend too much time on it, but you have antidepressants because depression usually goes hand in hand with dementia. You have medicines which are anticholinesterase. These are medicines that at best reduce the deterioration or stop the deterioration for some time. They do not improve it by much or significant. Antipsychotic medications, these are to maintain people who are having hallucinations or for people who have a lot of behavioral difficulties. Mood stabilizers can help, so they reduce the impulsivity, and the last one is tranquilizers, so they just make the patient a little bit drowsy. And help them sleep better. What about caregivers? Now, the process of caregiving is one of continued change and adaptation. The caregivers need to understand that the loved one is unable to understand or retain or have a good judgment and tell it back to you. They also have reduced ability to regulate their behaviors. A lot of times family members come and say, well, we can't look after them, they're doing it themselves or they're doing it on purpose. And it's actually not like that. They just do not know what's right or wrong. The process is tiring, obviously, and just like if you're traveling in a flight, the air hostess says, if the pressure is less, put your mask first, then help the next one. So you need to look after yourself first, and then you'll be able to give care to other people. If you can get some respite care, then it is usually helpful because you need to maintain your own well-being. Don't blame yourself or feel guilty about helping people into a care home or residential home for care. I mean, in India you have a choice, but if you were living abroad, then you may not have a choice, and the services might just take the person and make them reside in a nursing home or residential home. As I said, you have to help yourself first before you can help somebody else. Accepting the diagnosis is very important because that's the best way of planning future treatment, whether it is care at home or further medical needs or to look into a residential placement. Take one day at a time and do not anticipate future difficulties because they may never come. Offer gentle commands and requests rather than saying, what do you want to do today? Should we go out or should we do the laundry or should we cook food? Just say, let's do this. So it is easy for them to comprehend and understand. As I said, maintain patients' self-esteem by letting them do something. And finally, if you can't go anywhere, just blame the doctor. Say, the doctor has said no. I won't go much into these medicines, but sometimes they're the only choice to regulate behaviors. But they do increase the mortality, which means the death rates by double of people who are not. But sometimes you just can't avoid them. I won't go into this. All the medicines have a bit of side effects, which might be confusion, falls, which have difficulty in themselves. So as far as we can, we should try and use non-medical ways to regulate behaviors or help the person. I think we're taking the questions later, and
our last speaker of the evening is Captain Usha Banerjee, and she's going to be discussing the prevention of fall in the elderly.
Before I get a warning from our chairman here, let me switch on my stopwatch. And I'm really mindful that none of the other speakers here got a warning. Respected elders in this audience, dignitaries on the dais, off the dais, ladies and gentlemen. It's a great privilege and an honor to be here amidst you all. I thank Dr. Khandelwal and Apollo Hospital for giving me this opportunity to speak on the topic, prevention of falls in the elderly. I would like to start with a little poetic note, and I have tweaked this poem a little bit to talk and relate it to the subject. This is for all the elders, and I hope the youngsters in this audience would take up cues from this. I cannot see, this is how I imagine myself when I'm a little older. I cannot pee, I cannot chew. Oh my God, I have no clue. Tell me, what can I do? My memory shrinks, my hearing sinks, my word stinks. There's no sense of smell. I look like hell. My mood is bad. Can you tell? My body is drooping. I have trouble pooping. The golden years have come at last. Handling my life is a great task. And if at all I have a fall, it will be like from the heaven above. It's God's call. Friends, India's demographic time bomb is the elderly. The elderly are a part of a very little discussed topic in our country and an emerging concern, whose numbers are rising very fast, especially when the traditional extended family network is eroding due to socioeconomic transformations. In India, the size of the elderly population, that is people above 60 years plus, is growing, although it constituted only about 7.4% of the population at the start of this millennium. Mr. Charin has given you a lot of statistics, and I would also probably touch upon the same in my presentations. About 100 million Indians are above the age of 60, which is the world's second largest senior population after that of China. And the number will rise steeply to about 170 million in the next decade. And this would be slightly more than the population of France, with over 70 years old population in our country. And most of these retirees come from the middle class or more affluent groups where better healthcare access was available, nutrition, etc., increasing the lifespan of our elders far beyond the current national average of 66 years. Problems that are faced by the elderly: multiple falling health, economic insecurity, you know it all, I don't have to repeat. But I also am concerned about lack of preparedness for our old age. Falls. Fall-related injuries and the fear of falling in itself are important public health problems in our aging society. And this can threaten the independence and quality of life for our elders. Age is one of the key risk factors for falls. As you grow older, the risk of fall and death is much higher. This is some statistics from the United States where things are much more developed. And you might see here that the fatal and non-fatal fall injuries among people 65 plus years of age is of great concern. Millions of patients people have had fall-related injuries. About 75% of them are treated in the emergency department and released. 24% are treated in the emergency department and then hospitalized, and about 1% have died. And the multiple causes of which 31% accounts only to accident and environmental situations. Every 18 seconds, an older adult is in the emergency room. I work for the best hospital, and yet we are grappling with the problem of falls within the medical care setting. So that important is this concern of falls. Falls are the second leading cause of accidental or unintentional injury deaths worldwide. About 1/3 of the elder population over the age of 65 fall each year, and the risk of falls increases with age, and at 80 years, over half of the seniors would have had a fall. The risk of falling is greater in women. 2/3 of those who experience a fall will fall again within 6 months. A decrease in bone density contributes to the fall and resultant injuries. Failure to exercise regularly results in poor muscle tone, decreased strength, and loss of bone mass and flexibility, causing falls. So why fall prevention? It's the leading cause, as I mentioned, of unintentional injury. Affects 65 plus population more than that of stroke and heart attack. 60% of all the falls happen at home. 95% of the hip fractures result from a fall. 40% of those who fall are not able to return to independent living, and about 20% pass away. And they are 2 to 3 times more likely to fall again. And chronic medical conditions which plague our elderly can increase the risk, especially that of cardiovascular disease, diabetes, osteoporosis, etc. And believe me, falls can be prevented. This is a big problem, and you can prevent them with some simple steps and simple solutions. Identifying the problem, planning a personal and community strategy is important. And falls are not a natural part of aging. They can be prevented through good screening, prevention, and intervention. The many causes of falls: female gender, low weight, previous falls, etc., disturbed balance, coordination, gait disorders. You heard the doctor say some drugs can cause falls, etc. But let's look at the top 5 risks here. Osteoporosis, lack of physical activity, impaired vision, medications, environmental hazards. osteoporosis. All of us are probably very literate and educated, and most of you know this, but it is a problem. Osteoporosis is a disease in which the bones become fragile and more likely to break because they have become less dense. How can you prevent it? Eat or drink food rich in calcium, like yogurt, cheese, fish, shellfish, etc. Selected vegetables such as broccoli, soya bean, and almonds. And women must consult their gynecologist to have the appropriate dose of calcium and vitamin D. Lack of physical activity. Failure to exercise regularly results in poor muscle tone, decreased strength, and loss of bone mass and flexibility. All contribute to falls and the severity of injury due to falls. And trust me, most of our women, elders, do not have a good exercise regime. Prevention, regular walks, daily exercises, indulge in whatever you think is appropriate for your age and your situation. Have group walks, yoga, walking, swimming, whatever you like to do, but do exercise. And before that, please do consult your doctor to find out what is the correct regime for you. Impaired vision. Age-related vision can increase the risk of falling. Cataracts, glaucoma, all this can alter your depth perception, it can hinder your glare and the ability to negotiate with your environment, whether it is your home or outside. So have regular checkups by an eye doctor, especially to understand the age-related disorders that you might have. Use color and contrast to define balance aiding objects at home, example, your grab bars, etc., which we'll come to later. Improve the visibility of your glasses through regular cleaning. Medications. Simple medications like over-the-counter cough syrups, etc. And of course, many of them would be on sedatives, antidepressants, antipsychotic drugs, which can increase your risk for falls. So please review the medication with your doctor. Know the common side effects. Understand that there are early warning signs and take necessary precautions. Limit the intake of alcohol because this can add on to the risk. Environmental hazards, and this is what I think I would like to focus here on. At least 1/3 of the falls in the elderly involve hazards at home. You heard Dr. Khandelwal say that today there is a crunch for space and most of the elders live in crowded and a cluttered home. There are no facilities. We create fancy homes, but we do not take cognizance of the little things that our elders would need at home. So, example, poor lighting, loose rugs, lack of grab bars, or poorly mounted, located grab bars, unsteady furniture, etc. could be big risk. So how do we prevent this in our living rooms? Most of us like to have a lot of rugs at home, so kindly apply a non-skid tape and tape your carpets, carpet edges. Have at least one phone extension in each level of the home and post emergency numbers. I see a lot of youngsters here and I wish you do this for your elders back at home. Maintain night lights or motion sensitive lighting throughout the home. Today there are remote controls available to switch off your fans, switch on your fans, draw your curtains. I think a little investment is worth a medical instead of a medical complication. Bathrooms, this is one area that is a potential hazard for our elders. Most of the falls happen in the bathrooms. I keep insisting on the fact that we need to install grab bars. I did talk to a few of my elder doctors yesterday, do you have grab bars at home? And I was surprisingly told that no. So this is a problem. Around your bathtubs, around the toilet seats. Add non-skid mats to the bathtubs. Raise the toilet seat if it is required. Kitchen. Our women folk, elders are always in the kitchen. And they reach out to all top surfaces to pull out things. You need to understand that a simple fall could be really a major complication. So use a sturdy stool, Make sure that the cords and appliances are out of your way. Do not use slick surfaces and polish your floors to enhance beauty, but your care is more important than how the house looks around you. Bedroom. Put on bedside lights with a switch that is easy to turn on and off. Touch lamps are recommended. Locate telephones within the reach of the bed. Adjust the height of the bed to suit your needs. Have a firm chair. Many of our homes have these plastic chairs which are not really sturdy, with arms to sit and dress. Stairways, hallways and pathways need to be kept free of clutter. Make sure that the carpets, and we don't have these throw rugs around to prevent a fall. Install tightly fastened handrails running the entire length and along the both sides of the stairs. Apply brightly colored tapes on the face of the steps to make them more visible. Have adequate lighting in the stairs and hallways with light switches placed at both the ends of the staircases. Many preventable measures in the environment. Beds in low position, and if you're nursing a patient at home, have the beds on a break. Keep floors uncluttered. Remove all objects that could come in the way or could cause a potential injury. Perform regular preventive maintenance on all those mobility aids which are used by the patient or the elder family member. It should be a routine, it should be like a checklist every day that you've looked at the screws, nuts, bolts and the balance. Ensure that the clothing will not cause tripping, because we tend to wear loose clothing and we trip over. Try and wear slip-proof socks or shoes. Appropriately time the mopping of the floors, because most of the falls are close to the maid's arrival time. So try and finish all your needs and you do not step over onto those surfaces. Hearing and visual aids should be close by. Maintain adequate nutrition. Encourage to dangle before standing and walking. Don't just jump out of bed, because it can cause a little dizziness and you could fall off. Encourage the patient to perform ankle pumping in the sitting position to improve your circulation. Encourage to sit down immediately if you're feeling dizzy. Make sure that proper gait aid is used, and they should be available at the side of your bed. Provide visual cues. You just heard the doctor say dementia and a lot of other related problems that our elders are suffering from. These will remind you of safety tips, especially during transfers and ambulation. And I would like to say to all the elders in this room, don't fall for the myth that growing older automatically means you're not going to feel good anymore. It is true that aging involves physical changes, but it doesn't have to mean discomfort and disability. While not all illness or pain is avoidable, many of the physical challenges associated with aging can be overcome or drastically mitigated by eating right, exercising right, taking care of yourself. Each of us have that responsibility to prepare ourselves and our environment for the aging process. Thank you. I would just like to leave a message. What we have done for ourselves alone dies with us, but what we have done for others in this world will remain immortal. So each one, teach one, help each other to take care of yourselves. Let's take care of our elders. This is the message for all the youngsters here. They've spent a lifetime looking after us.